Hello, everyone. Good afternoon, and welcome to this series of the AFRH, the Association for Fertility and Reproductive Health Training Committee webinar series. We're very happy to have us on board again. After 2 weeks ago, we began a discussion on genetics of male and female infertility. So today we're going to be moving on that to having the part 2 session on behalf of the ESCO, the National Executives of the AFRH, and the local organizing committee and the training committee. We want to say welcome to this session of the training committee webinar series. So before I introduce the speaker, I just want to lay some ground rules that will help us to be able to have a seamless discussion. First and foremost, we want to ask everybody that is on this platform to mute his or her mic and remain muted throughout the period of this presentation until it is time for us to engage in asking questions and asking for comments to be made. We want, as the presentation is going on, if you have any questions or comments, you can post it on the chat box section that is in the under part or the lower part of your screen on the Zoom platform, or on the upper right portion of your screen where you have the Q&A written there. You can post your questions on either buttons, and then at the end of the day or at the end of the presentation, my co-moderator is going to be handling that. By way of introduction, I'm Dr. John Ekwani, a gynecologist. I'm with the Federal Medical Center, Abuja. I'll be asking my co-moderator, who is a barrister, to introduce herself so that we can hear her voice and so that she can greet the house. We have the honor of Barrister Halita on board. Can you please speak up and say hi to the house and introduce yourself?
Okay. Good afternoon, everyone. I'm Barrister Halita Dekunle.
All right. Thank you so much for allowing us to hear your voice. I also have on ground Dr. Latif Akinola, who is the head of the training committee. Sir, can you please say something to us?
Hello, good afternoon, everyone. Happy to be here to hear Mr. Uwa again to talk to us about genetics of male and female infertility. Thank you.
All right, thank you so much, sir, for honoring this platform today. So without much ado, I'm going to be going straight to introduce our speaker. Our speaker is Mr. Uwa Joseph Olayinka, who is a distinguished senior embryologist and geneticist with over 10 years experience specializing in pre-implantation genetic testing and transport IVF, and has made significant contributions to the field of reproductive medicine. He serves as an international editor board member for innovation in scientific tech and social ecosystem, and holds a postgraduate diploma in assisted reproductive technology from a university in Kiel, Germany. Olayinka also holds a master's degree in genetics and leadership in health management. He is the head laboratory services of Fertigold Fertility Clinic, and alongside provide professional support to other fertility institutions. He is a member of a number of professional bodies, including AFRH, ACE, ASRM, and ESHRE. He has, with his skills and dedication, contributed in improving the chances of success for countless couples facing fertility challenges. His passion for education and empowering others in the field of reproductive medicine is evident through his dedication to knowledge dissemination. With all pleasure and honor, I welcome Mr. Joseph Olayinka Owa. Please, you have the floor, and you have about 20 to 25 minutes for your presentation. Thank you very much. You can share your slide, and you have the floor. Thank you very much, Mr. Owa. Hello? Is Mr. Owa still with us? Hello?
He's not here at the moment. I'm sure he will join back shortly. Yes, he will join back shortly.
Okay. Okay, while we are waiting for Mr. Owa, probably network problems, I just want to give a few talks. This series is a part 2 of what was an introductory session that was done last 2 weeks, where Mr. Owa talked about the genetics of male and female infertility. He elaborated a lot on that, and these are eventually going to be compiled into notes, and we are hoping by the end of the day, with the editor-in-chief on board, we'll be having a textbook that should be quite of reputation in the field of fertility medicine to be compiled. So at the end of the day, I think this lecture series span out through the year, and I think even up to early next year, if I'm not mistaken. And it's going to be happening on a fortnightly basis until we are done, and then the editorial process will compile everything, and we'll have a robust document for sharing. For those of us who are yet to follow us on our social media handles, Facebook, YouTube, Instagram, LinkedIn, and the likes, just type at AFRH Nigeria, and I'm sure you will see our picture on our page. You can just click follow, and I'm sure many of the updates will be shared on a periodic basis and will keep up to date of our activities. Okay, Mr. Owa is back online. So thank you, Mr. Owa. Can you please come online, share your slide, and you can begin your presentation. Thank you.
Good afternoon. Can you see my slide now?
Yes, yes.
Okay, thank you very much. I want to apologize. I think it was a network issue, and I hope stable at point. So today we continue the webinar series for AFRH, and we'll be talking on a very important topic today, and it has to do with ART and genetic screening. Where are we now? And my name is Uwa Joseph Olayinka. I'm a clinical embryologist, and day is 23rd, 2025. So these are my outlines. We'll start from introduction, looking at histories and benefits and limitations of ART and pre-implantation genetic screening. So first, the concept of ART as a means to overcome infertility. You know why couples, they come for assisted reproductive technology to assist with conception. And IVF methods, there are various methods. In fact, the area of assisted reproductive technology and genetic testing has evolved over the last 25 years. And there's need for one to also adapt to changes, and the need for more efficient, streamlined diagnosis. And that is the whole essence or the objective of this presentation. But there are different methods in ART, We have the conventional IVF. We have ICSI, and ICSI, we have two aspects of ICSI that also innovative, which is ICSI and IMSI. I wouldn't want to spend so much time on explaining this. The physiologically, intracytoplasmic physiology, intracytoplasmic sperm injection, while IMSI is intracytoplasmic morphological stem injection. And a new aspect of this is the AFRH. I think some of us must have heard about this recent development because it has been discussed for a while now in the AFRH group. Is an innovative method that involves injecting the sperm into the perivitalized space of the egg, and this is known as assisted sperm fusion insemination. Others involve inseminating the gamete, egg, and sperm into the fallopian tube, and or inseminating the zygote into the fallopian tube, known as GIP and ZIP. There are several stages involved in IVF treatment, and basically genetic screening is a process of examining either individuals, gametes, embryos to ascertain their predisposition to genetic diseases. And there are different areas of genetic screening in assisted reproductive technology. We have the carrier screening, which is screening either the gamete or the sperm, the egg or the sperm, or screening the man and screening the woman for genetic abnormality. We also have PGS, which is pre-implantation genetic screening or pre-implantation genetic testing. Over the years, the nomenclature for pre-implantation genetic testing for both aneuploidy and monogenic diseases has changed over time from what we used to know as PGT, PGD, and PGS. And this adapting to changes in technology and the need for more efficient, streamlined diagnosis is made, like I said earlier. So pre-implantation genetic diagnosis and screening has been applied clinically for over 25 years. So what is pre-implantation genetic testing? We look at the history of pre-implantation genetic testing. Robert Edwards and Richard Gardner have done a lot of research, and they first demonstrated the identification of sex of rabbit blastocysts in 1968. While the term PGT was not used then, their research laid the foundation for future development, and other researchers were able to build on this, and this includes Alan Andyside and his colleagues within 1980s and early 80s and early 90s. They were able to further develop alternative to prenatal diagnostics, which was what was practiced earlier, and successful use of PGT in humans, specifically for sex determination in couples at risk of X-linked disorders. Then in the 90s, the first pregnancies following pre-implantation genetic testing were reported, and utilizing polymerase chain reaction for sex determination in couples at risk of having children with X-linked disorders. So these are just some histories. And like I earlier mentioned, I spoke about prenatal genetic screening, which used to be the in thing before pre-implantation genetic screening came. And there are three common prenatal genetic screening. We have the fetal DNA test, we have the chorionic villus sampling, and we have the amniocentesis. I wouldn't want to dwell so much on this because of time, but if we have time, we can look at how implantation genetic screening has evolved. So the process flow really for pre-implantation genetics for a client that wants to come for pre-implantation genetic testing, they need to carry out basic standard investigation. Inquiries is done in the clinic, and the doctor consultation and counseling of the client. After which the client is scheduled for treatment and stimulation protocol using ovulation induction is done. And when the client is ready, retrieval through ultrasound guided or directed follicular aspiration is done. After which ICSI is done. We must be particular about the use of ICSI to achieve fertilization. And after which after the sperm has been injected in the egg and fertilization has been achieved, the embryologist can go ahead to carry out day 3 hatching. Some do day 2 hatching, but the most common is day 3 hatching. Some do day 4, some do day 5. And some also at that point, at day 3, can also do cleavage biopsy, which we are going to look at in subsequent slide, and day 5 biopsy. It depends on the preference of the clinic. If is day 3 biopsy, that is day 3 hatching that is done, and also biopsy on day 3, sometimes transfer can be done, fresh transfer can be done on day 5. But before transfer is done, there is need for the results to be explained to the client and proper counseling done. So on day 5, there is either frozen or fresh embryo transfer. So this is just a process flow of how the events plays out for a client that wants to do genetic, that wants to do PGT via IVF. So what is pre-implantation genetic analysis itself? Pre-implantation genetic analysis laboratory technologies, because we are going to be looking at some techniques in PGT. And these technologies or these techniques are used to analyze genetic makeup of embryos arising from IVF. Like I said, we are particular about using ICSI, and after the desired embryo is seen, the embryo is transferred into the uterus. And the procedure which it involves removal of one or more embryonic cells. We are also going to explain this in subsequent slides to test for aberrations in specific gene sequencing. So either we are checking for chromosomal aberrations, or we are checking for monogenic diseases, which is most common. This is followed by genetic diagnosis through different techniques. Involves using either fluorescence in situ hybridization or PCR, ACGH, NGS, and different others. And this subsequent, like I said, the subsequent transfer to the patient of embryos classified to be genetically normal. So what are the potential sources where genetic material are gotten from? One, we have the polar body biopsy. This is using extracting the polar body of a mature egg and sent for genetic analysis. Another source of genetic material is the blastomere, which is the day 3 biopsy that I earlier mentioned. And the last source is trophectoderm biopsy, which is taking trophectoderm cells. Now, from recent technologies and studies and research being done, there is the last one, which is SCM, using non-invasive pre-implantation genetic testing. In subsequent slides also, we are going to look at this technique and how genetic materials are being gotten from it. So, but before embryos are biopsied, before the cells are being taken and sent to genetic lab, there is a process that, like I said, on day 3. Some do it on day 2, some day 3, some day 4, some day 5. Depends on the preference. So, but we have 3 ways through which either the zygote or the embryo or the blastocyst is being hatched. Assisted hatching is done via laser-assisted hatching. We also have mechanical assisted hatching. Laser-assisted hatching involves using a laser beam to drill the membrane of the zygote or the embryo so as to be able to access the cells. Mechanical hatching is the use of the either the biopsy needle or the ICSI needle to create a perforation in the membrane. And the last is the use of chemical acid to create a perforation in the membrane of the oocyte or the zygote or embryos. So these are 3 common ways through which assisted hatching is done. And like I said, the most common time this procedure is done is on day 3. After which we move to the next, which is embryo biopsy and tubing. This is a very delicate and an important aspect of genetic testing to get the cells out. And like I mentioned, biopsy is carefully taking a small portion of cells from either the trophectoderm or a cleavage cell. And this can be done at day 3, day 5, or day 6. And the aim is to obtain genetic materials without damaging the embryo or retaining the viability of the embryo. And after the cells have been extracted out, there is also a process. In fact, this is the most delicate process, like I always tell my colleagues, because at this point, there can be transmission or contamination as a result of extra DNA or particles being introduced into the PCR tube. And cell tubing, it involves transferring biopsy cells into the PCR tube containing either PBS or the cultural media. It depends on the genetic lab carrying out the analysis. And lastly, is the tubes are stored usually in cold condition until transported to the genetic lab for analysis. Most labs require that the cells are stored in cold condition so as to avoid damage of the cells or lysing of the cells as a result of heat exposure. So what are the types of pre-implantation genetic testing that we have? One, we have PGTA. Earlier in our last presentation, we spoke about the 2 common ways by which embryos or cells or human gametes are being analyzed. And the target is to either analyze the chromosome or to analyze the gene. So pre-implantation genetic testing for aneuploidy rules out deviation in number of chromosomes. So basically, it's all about the chromosomes to ascertain the number, the pairs, 23 pairs of chromosomes are exact and there is no deletion or no addition or any abnormalities in the chromosome number. Alongside, I will just shift this in, the sex, because the sex chromosome is also determined alongside. So the sex can also be determined, the sex of embryos can be determined through implantation genetic testing for aneuploidy. Then another is implantation genetic testing for monogenic diseases. This basically screens out mutations caused by single genes. We are going to look at some of those single genes. I think in our last presentation, we spoke about those common single genes that have been that we've been able to successfully identify and screen for. The another is pre-implantation genetic testing for structural rearrangement. Basically, is to reduce the risk of having a child with an unbalanced structural abnormality, probably a contribution from either the paternal or the maternal side, where there is a translocation in the embryo or there is an inversion. This causes structural imbalance in the chromosome. So PGT-SR basically is to identify those embryos that have structural or that are structurally imbalanced and they are removed. Then the last is pre-implantation genetic testing for, we're going to really look at this aspect, HLA. I know many of us is also known as savior sibling test. It provides a more direct way to find a compatible donor. So they are usually called donor embryos for a child that is in need of transplant, either a child that has leukemia or other genetic or diseases that may require a donor. So what are the benefits of genetic screening in assisted reproductive technology? One, it improves the pregnancy rate. Secondly, it reduces the risk of miscarriages, because one of the indications for carrying out pre-implantation genetic testing for aneuploidy is recurrent miscarriages. Then three, it enhances the success of treatment, because where the embryos are being screened, embryos that are free of any genetic mutations or aberrations, or there is any chromosomal aberrations are removed, and the embryos that are viable and that are genetically okay for transfer are being transferred, so the success rate increases, and it also prevents transfer of any genetic disorder from parents to offspring. So we spoke about methods in genetic lab analysis. For us, after the embryos have been biopsied and they are taken to the genetic lab, there are some techniques or procedures that are being carried out to analyze the cells, the biopsy cells, one of which is whole genome amplification. Is a robust amplification of the entire genome. We also have fluorescent in situ hybridization. Is a molecular cytogenetic technique that is used to localize DNA sequences on chromosomes. We also have PCR, which is one of the most common process that is being used mostly for PGTN to amplify or to make copies of specific target regions of DNA. That's basically for monogenic disease. Then we also have array comparative genomic hybridization is used in pre-validation genetic testing for aneuploidy to detect unbalanced chromosomal abnormalities in case where there is a deletion like Down syndrome and then duplication. So then we have the SMP, which is single nucleotide polymorphism. It analyzes copy numbers and inversions and translocations. So it's used also in PGTA. Then the most recent technology is the next generation sequencing. Is almost similar to the array comparative genomic hybridization, but it's unique in its ability to detect mosaicism, because sometimes too, I think in the last presentation we spoke about, somebody asked a question about using the 3 embryos of the 3 cleavage for biopsy and day 5. What is the difference? So for NGS, basically, from research and from studies, it has shown that you have high level of mosaicism in the 3 cleavage cells compared to highly differentiated cell, which is the day 5 cell or the trophectoderm cell. So for NGS, it has a very high ability or unique compatibility to detect mosaicism. So genetic disorders detectable by PGT So we're looking at genetic disorders detectable by PGTA using next generation sequencing. We have chromosomal changes. There is Down syndrome, which is having extra chromosome in chromosome 21. There is Edwards syndrome, which is trisomy 18. It affects chromosome 18. There is Patau syndrome. There is also Turner syndrome, which one of the X chromosome mostly affects females, and in males it is sometimes very detrimental. Then we have the Klinefelter syndrome, which is XXY, having an extra X chromosome. Then genetic disorders detectable by prevalidation genetic testing for monogenic diseases. There is carrier mapping, which is one of the techniques used. Then a next generation sequencing technique. So for this, we have type A and type B thalassemia. There's sickle cell anemia, which is also a monogenic disease. So these are various monogenic diseases. There's cystic fibrosis. We also spoke about this in our last presentation, and we mentioned that cystic fibrosis is not so common among Negroids, but it's common among Caucasians. It's also a monogenic disease. We have the Tay-Sachs syndrome. There is a Huntington's disease. There is a muscular dystrophy, hemophilia, and also albinism. So these are various monogenic diseases that using carrier mapping and next generation sequencing can be used to detect these diseases. Then for other monogenic diseases where we may need the ACGH technique, we have so most of these monogenic diseases are not so common among Negroids in the buckets lymphoma, mantle cell lymphoma, follicular lymphoma, the PTC, follicular thyroid cancer, acute, and different forms of leukemia, and so on and so forth. So all these are various monogenic diseases that can be detected using these techniques and also for chromosomal aberration. In the earlier slide, I made mention of the fact that we have some other or recent techniques that have discovered some other areas where cells or genetic samples can be gotten from. And today we'll be looking at the non-invasive pre-implantation genetic testing, which is NIPGT. So basically, recent discoveries of cell-free DNA within the blastocele fluid of the blastocyst and also in pent embryo culture media has led to this interesting development in pre-implantation genetic testing and is a non-invasive pre-implantation genetic testing. And what is basically done is that the cells after injection of the sperm into the egg is cultured till day 3, and after day 3, the culture dish is the resulting zygotes are transferred into another dish, and that dish is cultured till day 5. The spent embryo culture media depends on the particular media that is being used. It's believed that the blastocele content, that there are some cell-free DNA that have been seen, and some DNA fragments of DNA in the culture media. So after which this media is cubed and sent for genetic analysis, and results have been seen. However, the advantages are seen. One, it is less expensive, and it requires less manipulation skills, unlike pre-implantation genetic testing, where you need a well-experienced embryologist and geneticist to handle the procedures. For NIPGT, it doesn't involve so much specialty, and it possesses a very low risk to, or it poses a very low risk to embryos because, like we said, or like the name implies, it is a non-invasive procedure. So it doesn't involve you hatching the embryos or going into using a biopsy needle to extract trophectoderm cells or cleavage cells for analysis. So all it requires is the spent embryo culture medium that is taken and tubed. So it also requires single culture. That means the embryos are cultured singly so as to identify the embryos individually. However, there are some questions that have been asked. One is that, does it reflect the true genetic status of corresponding embryo, especially when it is compared with the outcome of pre-implantation genetic testing for aneuploidy? So does it also meet 85% concordance when it is compared with PGTA? Most times it doesn't meet 85% concordance because while you are carrying out from research and from comparative studies that have been done to know the difference or the result outcome, it has been seen that PGTA still has a higher accurate result compared to NIPGT. So, is there a chance of failed amplification? Yes. So these are some of the challenges seen. However, it's a very new field and innovative field in pre-implantation genetics testing, and there's need for us to explore this area of PGT. So when we talk about ART and pre-implantation genetic testing, what are the possible limitations that we? One is that there's insufficient number of good quality and developing embryos. Sometimes you have a client that you collect 10 eggs from, and at the end of the day, after injection, the embryo grade may not be may not be good enough after hatching and embryo biopsy is done. So there is really this challenge. Another is if there is a proven abnormal genetic finding in all analyzed embryos, and embryo will be recommended for transfer. So at this point, we like a case where we had a client that had few numbers of most of the embryos analyzed were unsuitable for transfer, and there is need for that client to be properly counseled. And there is also minimal risk of incorrect diagnosis. There is a chance that there is a 0.1% or about about 1 to 5% of incorrect diagnosis. There is possibility of it happening. Sometimes there is also sex mismatch. So these are limitations faced in pre-implantation genetic testing. There is also risk of inclusive diagnosis where conclusion cannot be reached. We have several cases where sometimes due to the number of cells or the result of analysis does not achieve the reference value determined by the test laboratory for a given procedure. So at that point in time, the result comes out as inconclusive, and there may be need for rebiopsy of such embryo. So what are the recommendations? One, adequate number of embryos biopsy for analysis to increase the chance of having the desired outcome. So part of the ways by which this has been done is to have cumulative cycles for clients, and most genetic centers, they are aware of this, and they will tell you you can do cumulative cycles when you have the number of required cells or number of the desired number of cells or embryos they can be sent, or they can go ahead to analyze sample. Also, knowing how to perform embryo biopsy at different stages help to better organize daily laboratory activities and to rescue some undiagnosed embryos after day 3 biopsy. Because sometimes it's also important for an embryologist to know how to carry out both day 3 embryo biopsy and day 5 embryo biopsy, and also the various hatching method, either using mechanical hatching, using laser assisted hatching, or using the chemical assisted hatching. So it is very important for an embryologist to be well informed and exposed to these different techniques. And in addition to everything that there are also hereditary genetic diseases that, although they do not cause sterility or they are not involved in infertility, prospective parents do not want to pass on such genetic diseases or aberrations to their offspring. So therefore, there is need for pre-implantation genetic testing to be done to avoid these pathologies. So hopefully, with the advent of the non-invasive pre-implantation genetic testing, when it becomes cheap, clients will be able to access this this technology in assisted reproductive or IVF treatment. Then mandatory counseling, both before the client is scheduled for treatment, during the analysis period when the result is out, and before the embryos are transferred. There is need for mandatory counseling, and IVF clinics will endeavor to have genetic counselors or have a genetic unit or employ the service of geneticists who can interpret and explain genetic outcomes to the client. Though from also X-ray, they've advised that the genetic test centers should also make the results as easy as possible so that non-geneticists can also read, understand, and interpret results. But there's actually need for genetic counseling, and clinics should include a disclaimer in the report to address limitations of PGT, because there is no way we can rule out the limitations or the possible limitations in pre-implantation genetic testing, ranging from clients not having desired embryos for transfer, or clients that requires a particular sex as a result of sex-linked mutation or disease, and any other information that may be of significance to the clients. So there is need for clients to be aware of all these shortfalls or challenges or limitations so that they are properly informed and due consent signed. In conclusion, from research and over the years, human embryos, they show great deal of acquired chromosomal abnormalities. To explain the success rate of IVF, this is reflective in the success rate of IVF. Hence, pre-implantation genetic testing for aneuploidy was developed to select euploid embryos for transfer. That means embryos that are intact, that have the exact number of chromosomes. Genetic screening in assisted reproductive technology has followed tremendous evolutionary breakthroughs. And currently, like I mentioned, next generation sequencing combining chromosome with single base pairs analysis has become the gold standard in both pre-implantation genetic testing for aneuploidy and for monogenic diseases. New techniques are being developed to detect both monogenic disorders and aneuploids concurrently, unlike where you have pre-implantation genetic testing for aneuploids and a separate test done for monogenic diseases. Like for monogenic disease, there is need for setup where genetic materials are taken from the parents and also the affected child. Like, for instance, a case of either sickle cell or albinism, there is need for blood setup or genetic setup before the main test is done on the biopsy cells. So, but with new technologies, hopefully, monogenic diseases and aneuploids will be detected concurrently, and improved accuracy through techniques like the NIPGT that was mentioned can evolve for a wider range of genetic disorders and complex traits. It also provides deeper understanding of embryo genetic makeup, and this could make implantation genetic testing more accessible and less invasive. At the end of the day, the client is what is is the happiness of the client and satisfaction of the client is what we seek eventually. So these are my references. And I want to acknowledge AFRH, my senior colleagues in CIAN, Dr. Akinsho, Petty Gold, Dr. Akinola of Medicine, Professor Makwe, Dr. Larry Waju, Uploid Medicals, Prof. Consult, members of Embryologist Roundtable. Thank you all very much for your support. M2 staff members, my mentees, Victoria, Tolu, Ben, Stephen, Deme, Uche, Miracle, Dolapo, and my family in the IVF business. Thank you all very much. Thank you once again. Dr. Kwani, thank you very much.
All right, thank you so much, Mr. Yinka Uwa. Thank you for that explicit and lucid presentation. I think one of two things actually stand out for me: the place of genetic counseling in all this, because one of the challenges we have in this kind of environment is being able to communicate explicitly to our clients in a manner that they will understand what is really going on. And then the other thing that also stands out for me is a situation where it is possible to co-test for both aneuploid and monogenetic disorders. I think I'll be looking forward to what that can happen, because a number of clients often show up looking for both aneuploid screens and monogenetic screens. I think if that happens, it's going to be a good addition to our ammunition in dealing with genetic and IVF problems. So thank you very much, Mr. Yinka. I'll hand over to my co-presenter, co-moderator from here.
Thank you very much, Dr. Ezeani. I don't know if there are any questions. Are there any questions? I see someone has asked for the presentation to be made available. I'm sure we learned one of their certain areas that are not clear to us. Please feel free to ask. He's here live.
Or if they cannot type, they can indicate by raising their hands and they can have the floor to speak.
I'm sure we all heard Dr. Ekwani. You can indicate by raising your hands so we can yield the floor to you. Okay, so thank you, Inikpi. Someone has asked if non-invasive PGT is presently practiced in Nigeria. I don't know if Mr. Uwa will want to quickly speak into this. Thank you.
Okay, thank you very much, ma. Non-invasive implantation is practiced in Nigeria, though it's not so common because of the challenges that we've enumerated, and hopefully once it is perfected, then but it's practiced in Nigeria.
Thank you for that answer. I hope it's clear. Okay, at this point, I would like to hand over to our chair, Dr. Ekwani. Thank you.
Thank you so much. My it's like another question has okay. No. Okay. These are just comments telling the presenter wonderful presentation. Can you glass through the first 16? All right, fine. So thank you very much for everyone comments and questions. You know, sometimes when it is should I say this quiet, you understood very well, or there are gaps in understanding. But whatever be the case, I think the presentations are a continuous process, and I believe it will be things will get better and better as the journey continues. I don't know if our overall chair, Dr. Akinola, can make one or two comments for us before we begin to close.
Thank you so much.
Dr. Akinola, are you still there?
Yes, I'm here. Yeah, I'm here.
Okay, sir.
Can you hear me? Yeah, thank you so much,
Okay.
Dr. Ekwani.
Yes, we can hear you, sir.
And
yes, sir.
Ms. Alita as well. Thank you so much. We enjoyed the lecture. Mr. Joseph has proven himself to be a good presenter. He has, done he has done a good justice to the presentation. And as the chairman of the chief moderator has mentioned, that at the end of the day, we intend to collate all these webinars together, polish it and make it publishable like a small textbook or a Bible for AFRH. And we enjoin all of us, including myself that will be presenting, to please, as we move along, let us continue to update our presentation so that at the end of the day, maybe, close to the end of the year, when we ask you to, give us this presentation back, this manuscript, it will be well, presented. We can send it to reviewers. They can review. They send it back to us. We make corrections, and we find a good publisher to assist in publishing it. I'm sure it's going to come out very well. I also want to talk about future presenters to please stick to the guide provided by AFRH so that when you are making your presentation, it will, conform to the standard. Talking about genetic screening in IVF, a topical issue. And we all know the benefit of, doing this genetic testing, the indications, and the types of genetic tests that are available. Yinka has, mentioned everything. from ICSI, conventional IVF, you mentioned that, the methods, ICSI, IMSI, PICSI, and all the newer techniques. And as we heard the last questionnaire, the questioner mentioned that, what about non-invasive genetic testing? I mean, this is becoming more and more available, and this not only to screen pre, but we can also use it even during pregnancy to screen the fetus. So it's quite an area that that is open to research and improvement in terms of methodology. Quite understanding, the presenter has done very good justice to it. He did one couple of weeks back. So this presentation will be made available. So there is no problem about that. We're eventually going to release it, to everyone. Thank you so much. And we look forward to the next one.
Thank you very much, sir.
In 2 weeks' time. Thank you, Joseph. Thank you, Dr. Ekwani and Ms. Alita. You are all appreciated.
Thank you, sir.
Thank you so much, sir. Yes, sir. So Alita, I think we have 2 people raising up their hands in the group. And we also have one typed question by an anonymous attendee. I don't know whether you can attend to that.
Okay, I can. Okay, so someone has asked, how can we make PGT more accessible to a wider range of fertility clinics? Many patients currently have to travel long distances, sometimes to other states, to access these services. I don't know if Mr. Ua can quickly answer that.
Okay, thank you very much, now. So basically, because of because of the equipment required for pre-implantation genetic testing, it requires the clinic having an ICSI machine. So if without the ICSI rig, the micro manipulation cannot be done for embryo hatching and embryo biopsy. So that is that's the limitation. However, like I said, with the advent of the non-invasive pre-implantation genetic testing, there is room, but the limitation still is one for having the equipment that is required. But for places where the equipment is available for biopsy and for hatching and for biopsy, the cells can actually be transported to any place. So its PGT really is, it can be accessible anywhere in Nigeria as long as the clinic has all the equipment that is required to carry out the assisted hatching and the embryo biopsy. I hope that is clear.
Okay. I hope that is also clear too. We have another question. Someone has asked what the difference is between PICI and IMCI. Mr. Ua, please.
Oh, okay. So basically, PICI, that is physiological intracytoplasmic stem injection. That's PICSI. Whereas IMSI is intracytoplasmic morphological sperm injection. So for the difference is for PICSI, it focuses on selecting sperm based on their functional quality rather than just visual appearance, which is the primary method in the conventional ICSI. And the process is it uses hyaluronic acid. Mature sperms, they have certain receptors for hyaluronic acid. So a molecule found in the cumulus phosphorus, it binds with the sperm cells. So during PICSI, sperms are exposed to hyaluronic acid, and only those that can bind to it are considered mature and selected for ICSI. Whereas for intracytoplasmic morphologically sperm injection, which is IMSI, that is actually looking at the vacuole of the sperm, and it's done in a very high magnification, and it's to check the number of the vacuoles and how big the vacuole of the sperm is. So they are classified into three: class 1, class 2, and class 3. So class 1 and 2 are normal sperms, whereas class 3 are abnormal sperms, where you have more than 25% of the sperm having vacuole, and also not more than five vacuoles being present in the sperm head. So IMSI looks at the number of vacuoles, whereas PICSI looks at the physiology of the sperm, how the sperm binds to hyaluronic acid. So that determines whether they are mature and good enough for ICSI. So that's the difference.
Thank you, Mr. Owa. Someone has asked if ICSI must be done before PGT, and what about hatching stroke biopsy of embryos from conventional IVF? Kindly attend to this.
Okay. So like I said, I emphasize on using of ICSI because one, from conventional IVF, you have a lot of DNA being exposed, whether to the embryo or to the media that is being used. And because of that, because for conventional IVF, the genetic material is the DNA is all over the cell. So where hatching is done and biopsy, there is high risk of contamination, either from the media or from the extra DNA particles that are around. So best practice is the use of ICSI, which is controlled because only one sperm cell is injected into the egg, unlike where you have conventional IVF, several sperms being attached to the membrane of the egg. And eventually, even when the embryos develop, you still have sediments of DNA being deposited around the membrane. So where hatching is done and biopsy is done, in that process, all those extra DNAs can also be picked, which will not give accurate results of what the embryo or the genetic complement of the embryo is. So that's why we emphasize on ICSI for pre-implantation genetic testing. I hope that is clear.
Okay, I think two people are raising their hands. We have Deborah Odega. No, can she speak up? Or she has put down her hand. All right. I don't know, Barrister Alita, I don't know whether you have any other questions to attend.
No, there are no other questions. Thank you.
All right, thank you so much. Okay, thank you very much. I think we'll bring this to a successful close. I want to sincerely thank Mr. Olayinka Owa for preparing for this outing. I know it's not an easy thing to do. Preparing for such thing takes a lot of work, and you can see he rightly acknowledged the role of collaborations in his acknowledgement sections, meaning that for one to do such great work, collaboration cannot be ruled out. So we thank you for that, and I believe subsequent editions will all have all of us on ground and on deck to attend and contribute meaningfully. So thank you so much. Once again, I want to
Thank you very
reiterate
much, sir.
that you kindly follow. All right. Kindly follow our social media handles on all the platforms, X, or formerly known as Twitter, YouTube, LinkedIn, Facebook, Instagram, and the likes. And just type AFRH Nigeria at AFRH Nigeria, and then you just click the follow handle, and you will keep up to date with our live updates concerning all our activities. So once again, on behalf of the training committee and the central executive of the AFRH, I want to sincerely thank all of us for attending this session and making it a worthwhile session. And to my co-moderators and all members of the secretariat, we want to say thank you. So we wish all of us a good night rest as we go ahead with our activities for the week. Thank you and God bless you. Have a great day.
Cheers.